Welcome to Scrubbed In, Narratives from the Front Lines, a podcast from the University of Tennessee Health Science Center College of Medicine, created in partnership with the Teaching and Learning Center. This is a space for reflection and storytelling, where medical students, residents, and faculty share the real moments that shape the journey of becoming healthcare professionals. Also, please take a moment to follow or subscribe and share this podcast with a friend, colleague, or fellow student. Our goal with each episode is to explore the challenges, triumphs, and unexpected lessons that come with learning to care for patients and remind us that medicine is as human as it is clinical. So whether you're a fellow student, a seasoned clinician, or simply curious about the human side of medicine, we invite you to listen, connect, reflect, and scrub in. Let's move to the front lines.
Thank you all for joining us for our latest episode of Scrubbed In, Narratives from the Front Lines. I'm your host, Emma Brennan, and I'm a first-year medical student.
And I'm your co-host, Ria Vlaliker, also a first-year medical student.
And we're excited to welcome Amelia Molis as our narrator for today.
Thank you so much for having me.
Before we begin, please hear this introduction for today's episode from Assistant Dean of Clinical Skills Training and co-executive producer of Scrubbed In, Dr. Rebecca Shapley. The whole art of medicine is an observation, but to educate the eye to see, the ear to hear, and the finger to feel takes time, and to make a beginning to start a man on the right path is all that you can do. Sir William Osler. It sounds so simple, doesn't it? Just observe the patient and you are on the right path. Yet we must learn biochemistry, anatomy, JAK kinase inhibitors, Krebs cycles, and prenatal neural development. The basic sciences are fundamental to educating the eye to what we must see, yet they do not teach the eye to see. It is so much more. Being able to observe the patient, notice the downcast glance or the bulging infant's frontanelle, or the awkward high-stepping gait, or to notice the subtle changes in demeanor of a patient over time, and being able to observe, diagnose, and consult the patient in a kind and empathetic way. In these first years of medical school, sometimes the art of observation plays second fiddle to mastering these basic sciences, but have no illusion. The art of medicine is an observation of the patient and the ability of the eye to see, the ear to hear, and the finger to feel. Listen closely to the stories of your seniors as they tell you the lessons they have learned. Listen closely to the stories of the patients, for as Dr. Osler also told us, nothing will sustain you more potently than the power to recognize in your humdrum routine, as perhaps it may be thought, the true poetry of life, the poetry of commonplace, of the plain, toil-worn woman, with their loves and their joys, their sorrows and their griefs. Last time we talked about the importance of practicing intentionality in healthcare, paying attention to details, engaging with patients' stories, and creating a process for diagnostic procedure were all critical components to this.
With the broad overview of intentionality under our belts, we're going to dive into some of the more specific factors. The stories we have today will highlight the importance of observation and avoiding assumption.
It is natural for us to come into any scenario with pre-existing biases. We are all human, after all. However, as physicians, these pre-existing biases can have detrimental outcomes if we do not work to acknowledge and avert our assumptions.
That's right. As physicians, it is our duty to not only observe closely, but to leave our assumptions at the door when we observe.
And with that, let's jump into our first story. To respect the patient's privacy, names, and identifying details have been changed while keeping the story's meaning true to the experience. Take it away, Amelia.
It was right there, Gower's sign. A classic buzzword, a hallmark physical finding that every medical student is taught to recognize. And yet, I missed it entirely. Why? Simply because I wasn't looking for it. Thankfully, during rounds, my attending didn't just see it, she seized the moment to teach our entire team a crucial lesson, to see the whole patient, not just a chief complaint. To rewind a bit, this moment happened on my second day of my pediatrics rotation. I was already feeling overwhelmed. Nearly everything I had learned in medical school so far seemed to apply only to adult patients. Pediatric medicine was a new language. Different physiology, different dosing, different diseases, and most challenging of all, different communication styles. I had been assigned to pre-round on a young patient admitted with pneumonia. My residents kindly gave me everything I needed to succeed: discharge guidelines, key signs of respiratory distress, and the criteria for safe discharge. With a checklist in hand and anxiety in my chest, I walked into the patient's room. The child looked great. He was cheerful, energetic, sitting on the floor, playing with his toys, breathing comfortably on room air. He had no cough, no fever, no wheezing, and a reassuring pulmonary exam. I remember thinking how muscular his legs looked, which struck me as unusual but didn't trigger any alarms. After all, some kids are just built that way, right? I returned to the team and presented my findings confidently. I gave a thorough report on his respiratory symptoms, his progress during his hospitalization, and my assessment that he was stable for discharge. The team seemed satisfied until we entered the room together and the attending asked the child to sit on the floor and then stand up. Puzzled, I watched closely. That's when I saw it. The child placed his hands on his knees, then his thighs, using his upper body to push himself upright. Classic Gower's sign. The room suddenly shifted for me. This wasn't just a pneumonia case. This was something bigger. The attending gently began a conversation with the family, asking about missed milestones, family history of muscular disorders, and any concerns they might have had. The mother admitted they'd missed some routine visits, but insisted her son seemed healthy. Still, this clue couldn't be ignored. Because my attending looked beyond the presenting symptom, seeing the patient, not just the problem, this family was able to begin the journey towards a potential diagnosis. They were referred to a geneticist for further testing, and we discussed the possibility of a muscular dystrophy diagnosis, such as Duchenne. That day, I learned far more than I expected. I learned that the physical exam is not just a formality, it is a powerful diagnostic tool, especially in pediatrics. I learned that tunnel vision, even with the best intentions and preparation, can blind us to critical signs. Most importantly, I learned to approach each patient with curiosity, humility, and a wide lens. Medicine is not just about solving the problem you expect, but also about uncovering the ones you don't.
As you heard at the end of that story, this case really highlights the importance of seeing the whole picture, looking beyond a single symptom or buzzword.
Exactly. In the rush to find a diagnosis, it's easy to latch onto the first idea or clue that fits. But that kind of tunnel vision can lead to missed or incorrect diagnoses, and ultimately, patients don't get the answers or care they need.
So the question becomes, how can we practice complete observation? One approach is to use a checklist, not just to make sure you cover key points, but to remind yourself to approach every case with fresh eyes, free of assumptions.
Right. Take the time to write down what you see in the moment, every detail, even the ones that seem small. Then, step back and think about how those pieces fit together. Medicine isn't about finding one clue. It's about assembling the whole puzzle.
And that leads us to our next story, because observation doesn't stop at noting symptoms. It's also about asking the right questions that bring you closer to the truth behind them.
Hey, thanks for checking out the Scrubbed In Narratives from the Frontlines podcast. If you're enjoying this episode, take a moment to follow or subscribe wherever you're listening, and help us grow by sharing it with a friend, colleague, or fellow student. You can also connect with us on all social media platforms or email us at pcmcourse@uthsc.edu with your thoughts, reflections, or questions. We'd love to hear your story too. Okay, now, let's get back to the front lines.
During my psychiatry rotation, I met a lot of patients struggling with alcohol use disorder. Their stories were rarely simple. Many were dealing with withdrawal symptoms, depression, unstable housing, and frequent readmissions. Over time, I started to notice how quickly all of us, myself included, made assumptions about them. We'd say things like frequent flyer or non-compliant, not out of malice, but habit. Those labels became shortcuts, and they quietly shaped how we saw our patients before we even walked into the room. One patient stands out to me. One day, a middle-aged man came in, well known to the service. He had a long history of alcohol use disorder and had been admitted multiple times before. He was confused, nauseated, and vomiting. His chart read like a familiar story, and the team quickly settled on the assumption that he was in alcohol withdrawal again. We ordered the usual labs and started standard management. Several hours later, the results came back: profound metabolic acidosis and extremely high blood glucose. He wasn't in withdrawal at all. He was in diabetic ketoacidosis. The realization landed like a punch to the stomach. Our anchoring bias had led us astray. By assuming we knew the case, we had stopped asking the right questions. Our delay in recognizing what was really happening prolonged his suffering and could have led to something much worse. That case stayed with me long after he recovered. I remember replaying the moment in my head, wondering what small clues I'd missed. His symptoms had fit more than one diagnosis, but I hadn't taken the time to explore any of the other possibilities. I realized how dangerous it can be when familiarity replaces curiosity. Even the most sophisticated tests can't help if we stop thinking critically or fail to see beyond our assumptions. Looking back, that experience was one of my most important lessons in clinical reasoning. It reminded me that every good diagnosis starts not with technology, but with a thoughtful, open-minded history, physical exam, and differential diagnosis. Those skills are what help us gather the information needed to make sense of what's in front of us. Without them, even the best tests can point us in the wrong direction. It also reshaped how I view empathy in medicine. I used to think empathy was mostly about emotional support, showing kindness or listening to patients' fears. I've learned that empathy also sharpens clinical judgment. When you truly listen and approach each patient without assumptions, you open yourself to clues that might otherwise go unnoticed. Compassion and critical thinking aren't separate skills, but completely intertwined. Each patient encounter is an opportunity to begin again. Start fresh, ask questions, and see the person, not the stereotype. The lessons you learn from listening will stay with you long after you leave the exam room.
When familiarity replaces curiosity. I believe that line perfectly sums up this story. When we repeatedly see similar cases, it's easy to apply our previous experiences and perhaps biases to these unique cases, subsequently disregarding crucial diagnostic steps.
This is especially amplified when we deal with stigmatized disorders and diseases.
Exactly. Each patient we see is a unique case and should be treated as such. Even the same patient seen on different occasions should be treated with the same respect.
And while we can draw similarities that help guide us, we should not let these assumptions distract from the fundamentals of diagnostic exploration and the development of a personalized treatment plan.
And we cannot let our biases affect the vital art of observation. And observation doesn't have to be purely clinical in nature. It can be personal as well. In our final story for this episode, let's observe how a medical student put their skills into practice to see and treat a patient as another human being. This story begins while I was on my family medicine junior internship rotation. I was beginning to have more autonomy in making my own plans and truly having my own patients to care for. I got a call from the ED about a man in his early 30s who had come in after a seizure. After talking to him and getting a history, I found out he had been a heavy drinker for many years, but recently stopped when he got called a day and a half ago to start a new job. It was around 30 hours after his last drink that he had had a seizure. This had never happened to him before, and he was rightfully scared. After further workup and normal neuroimaging, it was determined it was most likely an alcohol withdrawal seizure. However, despite his heavy drinking history, his liver was not yet cirrhotic, and he was at a point where stopping his addiction now could alter his future. I saw the hope and wanted to help him quit. However, upon presenting my plan of benzodiazepine taper to a resident, I was told it was a good plan, but one that the patient would certainly not adhere to. The residents on the team had a lot of skepticism. They had seen this story before and assumed he would follow the familiar path of leaving the hospital against medical advice, only to come back again seizing in a few days. Their doubts reflected the fatigue of repeated disappointments and the tendency to guard against investing too much hope in patients who struggle with addiction. I remember feeling unsettled by those assumptions, because even though I was just a medical student, I saw the possibility of willingness to change. I mean, after all those years of alcoholism, he had just started a new job and stopped drinking cold, which caused this in the first place. After he was admitted to the inpatient floor and started on the taper, he began to question if he needed to stay. He didn't understand why the alcohol caused his issues. He thought they helped it. He said that whenever he was shaking prior to the admission, drinking more alcohol helped. The next day, I decided to talk him through what was going on. I went to his bedside and explained the pathophysiology of alcohol withdrawal, describing how the brain adapts to alcohol over time and how sudden cessation can result in dangerous overactivity of the nervous system. I explained delirium tremens, highlighting the risk of seizures, which he knew all too well now, and death. I also explained why the benzodiazepines helped. He listened intently, and I could tell that he understood why completing the taper mattered. More importantly, he told me he wanted to change before he was beyond repair. Our conversations continued over the next few days. He spoke about his family, who wanted to see him succeed and who were ready to support him. I explained that this was not only a physical problem, but also one he needed to tackle mentally, so his family would be an important part of this journey. While the residents still had doubts with each morning on rounds, I saw him progress each day and began to realize that he was more than a patient. He was a man trying to reclaim his life. Midweek, I rotated off the medicine service and saw patients in clinic, but I still made time to visit that patient. I showed him someone genuinely believed in his ability to change and didn't see him as a lost cause just yet. And that time impacted me too. Those visits after clinic reinforced the importance of consistency and presence in patient relationships. By the end of the week, he completed his taper successfully. What had been dismissed as a likely failure by some residents had turned into a success story. And it wasn't because of anything extraordinary I did, but because someone was willing to believe in him, explain why his seizure occurred, and walk alongside him through the process.
This story really speaks to how powerful observation can be, not just in the physical sense, but in understanding the psychosocial side of medicine.
Definitely. The student in that story noticed something many of us forget, that this patient wasn't just defined by his history or his chart. He wanted to get better. Sometimes what patients need most is for someone to believe that they can.
And that belief isn't just emotional support. It actually does change how we care for them. When you approach patients with trust and curiosity instead of judgment, you pick up on details that you might not otherwise notice.
Exactly. The resident team might have seen another frequent flyer, but the student chose to see a person with a story worth hearing. That shift in perspective is what empathy in medicine really looks like. It's both compassionate and clinical.
It's once again a reminder that every case deserves a fresh start. Even if the presentation feels familiar, no two patients are the same.
Yeah, and it's easy to get jaded or fall into habits, especially during long rotations or when working with chronic conditions. But treating each patient with new eyes keeps us grounded and helps us stay or become better physicians.
And ultimately, that's what intentional observation is about, slowing down enough to see the patient in front of you, not just the diagnosis on the chart.
And that concludes our episode for today. We hope you enjoyed listening to these stories and reflecting on the importance of avoiding assumptions in your interactions with patients. Thank you to our storyteller, Amelia Mullins, and our producers on the PCM team, Dr. Abdullah and Dr. Shapley.
And of course, we want to thank the authors who submitted their stories for today's episode. We hope that their words have encouraged you all to consider the ways observation can benefit your medical practice, now and in the future. This has been Scrubbed In Narratives from the Front Lines. I'm Emma Brennan.
And I'm Ria Valaliker.
You've been listening to Scrubbed In, Narratives from the Front Lines, a UT Health Science Center College of Medicine production in collaboration with the Teaching and Learning Center. If any of today's stories moved you, challenged you, or inspired you to see medicine through a new lens, we want to hear from you. Connect with us on all social media platforms at UT College of Medicine or email us at pcmcourse@uthsc.edu. And for info about the Principles of Clinical Medicine course and or other educational initiatives from the UT College of Medicine, visit uthsc.edu. Until next time, stay curious, stay compassionate, keep learning, and keep scrubbing in.